Good afternoon, everybody. My name is Matthew Gibbs. I'm a consultant in anesthetics at Groote Hospital. Wonderful to have so many online this afternoon, and hopefully more people will come to join us shortly. Want to thank the Gastro Foundation for hosting this iEcho meeting. It's an association with Project iEcho from the University of New Mexico. And we're grateful for the opportunity to have these regular patient blood management sessions hosted on this platform. And there's been some fantastic talks on the subject over the last few years. These sessions are held weekly on a Wednesday, and they also include gastroenterology, hepatology, amongst other topics. The chat will be open for any questions. So please feel free to post questions there, and we'll answer them when we get to the end of this session. I just want to say a special word of thanks to the speaker this afternoon. I want to introduce Dr. Claire Barrett, somebody who I've really enjoyed working with. We've published a number of articles together, particularly on patient blood management. There's back in 2019, we published on the need for patient blood management in South Africa. And that need for appropriate use of patients' own blood hasn't really changed. And there, in fact, is even more relevant in this post-COVID day and age. Dr. Barrett is a senior lecturer at the University of Free State. She's a specialist physician and clinical hematologist. She is a well-published researcher. She is editor-in-chief of a well-known blood transfusion journal, Africa Sanguine, in Africa. And she's got a passion for anemia. So there's so much for us to learn from Claire today. So I'm going to hand over to Claire as she talks about patient blood management in our circumstances, in our area, and how we can use it. Claire.
Hi there. Thank you so much for inviting me to present. I just want to make sure, can you see my screen?
Yes, we can.
Yeah.
Okay. Thank you very much. So it's an absolute privilege to be able to share on this platform, and I want to thank everybody for making time. I know the afternoons are precious time with family, and I really appreciate the invitation and to talk about something that I really get so much joy out of, and that's patient blood management. The thing that I think is very special about PBM is that there is so much to do, and there's so much work for all of us to do. So there's really a space for each of us to make our mark in the world. I've sort of tongue-in-cheek said why, when, where, how, and who. And just to give a sneak peek about the who, it's going to be you. So let's kick off. So if you look at the world, there you will see that all the countries are marked in different colors, with dark green being high income countries, the lighter green upper middle income countries like South Africa, Namibia, and Botswana, and upper middle income countries in the sort of softer lilac and the darker lilac in low income countries. And what is really overwhelming to see, and you don't need to be sort of, even if you're partially sighted, you can see that most of the low income countries are situated in Africa. And this is devastating. But it also shows that we have really got a huge, big role to play in this talk, and what we can do and implement hopefully from listening and getting some ideas from this talk. And yeah, but there's a huge disparity in what we see in terms of income in the global north versus what we have here in Africa. And just to sort of put it into perspective, you can see in sub-Saharan Africa, really, the majority of countries are low-income countries. So just in terms of disclosures, I just wanted to say that I have previously had honoraria from Messina, but otherwise I'm my own independent thing. To kick off, I just want to remind everybody on the group what PBM is, because I think we all do come from different backgrounds, but PBM is a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. And I've tried to sort of highlight the different concepts within this definition, but it really is quite an exciting definition, and it's got so many different sort of action words in it. But for me, the thing that I see coming through really strongly is that this is a patient-centered management approach, and that we need to keep the main thing. So while this is patient-centered, we know that PBM is built on 3 pillars, and those 3 pillars is pillar 1 is to detect and manage anemia, and especially iron deficiency. And that's, I think, where gastroenterology, who kindly hosts this, comes in a lot. But also, the second pillar is to minimize blood loss and optimize coagulation. And then the third pillar is to leverage and optimize patients' physiologic tolerance to anemia. But I think it also speaks a lot to the physician's tolerance, or the surgeon's tolerance, or the anaesthetist's tolerance to anemia as well. So we've got to all, with the patients, tolerate this anemia better. PBM is then largely divided up, besides those 3 pillars, into a preoperative phase, an intraoperative phase, and the postoperative phase. So the message that I take from this is that this is really very perioperative. And by the end of this talk, I want to challenge you that perhaps in the sub-Saharan Africa context, perhaps PBM is so much bigger than these 3 pillars and these 3 phases within the pillars of preoperative, intraoperative, and postoperative, and that our role to play is much bigger than just in this phase. So, like we said, that the patient is the center of it all, but this patient generally is supported by an anaesthetist in the context of the perioperative phase, obviously then a surgeon or a gynecologist. Every now and then a physician gets involved, and a very underwhelming role player in patient blood management, I think, is the general practitioner. And I think that there's a huge role for us as people, I want to say as activists, to get involved and get more general practitioners involved, and that we keep thinking of this thing as a perioperative need, but this is so much bigger. And I really believe that we need to start calling this a public health problem and not a perioperative problem. And obviously these are now supported then by, you know, all the other allied health services who have tried to depict in various pictures there, and funders with a little piggy bank, just to, you know, really play a big role in how we roll out patient blood management. And I think that this is specifically relevant in the South African context, where funders, I believe, are one of the large impediments to an effective implementation of PBM in our context. I had the privilege of attending a meeting in Greece earlier this month, and this slide really impressed me. So this was a comparison between patient blood management and optimal blood use. And I just want to sort of hammer this point home, that patient blood management at no time is about saving blood. Yes, it does have the advantage of saving blood, but that's almost a collateral advantage, and it's certainly not what the intention of patient blood management is. Patient blood management really focuses on the person, and that the person is part and centered in this decision making, whereas optimal blood use focuses on the transfusion. You know, which bag of blood should I give? Should it be old blood? Should it be fresh blood? Should it be 1 bag of blood? Should it be 2 bags of blood? You know, the focus is completely separate in terms of where the decision is made. In terms of patient blood management is so much bigger than anemia. Although, you know, if I had to choose a favorite pillar, my favorite pillar is definitely anemia and the first pillar of PBM. But PBM, obviously anemia is a massive big part of PBM, but it also involves bleeding and coagulation as well. Whereas optimal blood use focuses on evidence-based transfusion practice, and really doesn't, you know, while, you know, in part it would maybe have a look at some of the use of FFP or platelets in terms of bleeding and coagulation, but it doesn't encompass the testing, you know, like TEG and, you know, all of these other things that we would then do to actually manage that coagulation. It's product-centered and not, the whole picture. So PBM is all about the patient's choice, whereas optimal blood use focuses on, did I consent this patient properly? Did I tell them about the risk of an adverse transfusion reaction? Did I tell this patient about, HIV risk and so on? Whereas, PBM is more just about a choice. So PBM really wants to look at protecting and building a patient's own blood and not looking at improving component utilization. So in general, the target of PBM is improved blood health, whereas optimal blood use really looks at the improved use of blood. So I think that every drop of blood counts. I think that we must not forget that PBM does have a very important role in making sure. So if I go back to this, sorry. So it's not that I don't believe in optimal blood use. We have to, PBM doesn't exist without blood. So we have to make sure that we use this blood optimally. But the message is more that just that it is so much bigger than optimal blood use. So every drop of blood really does count. I'm not knocking the protagonists for, what is the transfusion trigger. That research is important and that work is important. The drops of blood count, whether it's for the donor to make sure that this donor blood is used appropriate. It's very important for the patient. Did that drop of blood that was taken too many drops of blood taken for all the unnecessary tests that I had? It's important for the patient, but it's also important for the doctor, and it's very important for you and me as well, that we manage our patients properly. So the best blood for any patient is the blood in their veins. And I think we must say that again. The best blood for the patients is the blood in their veins. And we need to move away from wanting to transfuse every patient who is anemic. So PBM has had a long history. The World Health Organization published this in 2011, so it's already 12 years ago, where they made these priorities for action. And I quite like the way that they divided it up into a hospital level, a country level, and then a global level. And I'm just going to show you how PBM has evolved in these three spheres. So at a sort of an institutional hospital level, they've made these 10 recommendations on how PBM should be implemented. But one thing that you will see is that this is still very product focused. So how much blood should I give? Should we measure who's getting what blood? But here and there are little sort of PBM thought processes coming through, and those are marked with the arrows. We need to assess the clinic and physiological conditions for deciding on a transfusion. But that still does speak to a transfusion trigger. We need to set up multidisciplinary teams for managing blood use in patients. But again, you can see that this is about use, it's not about anemia management or coagulation management. And then I quite like this point number 10, and remembering that this is a 12-year-old document, is that we need to start collecting a minimum set of data on patient transfusion outcomes. And I want to challenge you, from whichever center that you represent, is this being done in your center? On a national level, again, a similar thing. This is very product-centered again. Again, at point number 5, establish a minimum data set that can be captured at each hospital. But this needs national guidance. There's a sort of a strong move to encourage multi-center studies that looks at patient outcomes and alternatives. And I really want to commend the surgical disciplines and anesthetists for being involved with, these big studies like the South African surgical outcome studies, and where they have built in anemia and outcomes related to that. And that is really commendable. And I really hope that you go from strength to strength with doing things like that. But can we make this bigger and get more data? We need to start looking at benchmarking more seriously. And how do we make sure that what happens in my hospital happens in your hospital? We need to provide more training for clinicians, nurses, and midwives on appropriate blood use. Again, this is very product-centered, but it remains important. Number 14, we must focus on outcome research. And I think that is so important. We need to sort of move beyond describing how many people have got anemia. And that is it's it is a very important data, and those are sort of easy wins. What percentage of our population is anemic? But we need to start stretching ourselves and see, well, how did this anemia change anything? Did it change anything? And how much did it change anything? And importantly, what did fixing the anemia do? Because that type of data we can use to leverage and make for change. So we need to make our research available so that it can translate into action. On an international level, again, this is probably a bit too big for you and me, but there's a challenge to collect global data on blood use and transfusion outcomes. So blood use data, the WHO has really been great at collecting such data with great support from the blood transfusion services globally. But transfusion outcomes, I don't think are collected as meticulously. And we need to promote and support research on inappropriate blood use in developing countries. And I would want to rephrase point number 6, because I believe that in developing countries, a lot of the inappropriate blood use might actually be better described as patients are being inappropriately under-transfused. And we must be careful to sort of keep looking at how low can we go in terms of how little blood can we get. And one of my theories is that if PBM was implemented in Africa on a large scale, I don't think that we'd see much less blood being used if we're using a transfusion trigger as a metric. But because I believe that we are grossly under-transfusing in many centers, and often because we just don't have enough blood to transfuse. Fortunately, that's not so true in South Africa, but I think in many other African countries it is true. And we need to start disseminating information more. And I think that there are champions that have taken this to the next level, and Vernon is certainly one of the people that I just take my hat off to, for his energy and enthusiasm, and setting up this WhatsApp group and how effective it is in sharing information. And I hope it never stops. And I hope that each little hospital starts developing their own little WhatsApp groups where they can share more and more information. But we need to share what we learn. And then we also need to look at developing a generic curriculum for nurse and medical students on blood use, because I think this comes to sort of the globalization of education, and what COVID has taught us, and even how gastro-echo has come about is, we can be sitting all over South Africa, we can be sitting all over Africa, but we're all listening to the same thing. But so if we can all learn together and present lectures together, surely we can also work together to make a generic curriculum that sort of can be copied and pasted with a little bit of tweaking for the Lesotho nursing program, for the Madagascar nursing program, and that we can share with each other, because I think that that is a huge win, rather than letting each little institution come and have to develop their own programs from scratch. And that I believe is a huge, big challenge, and something that maybe there's somebody in this room that really could be part of that solution. So 10 years later, the World Health Organization came up with another document. So the document there was an action framework to advance universal access to safe, effective, and quality assured blood products. So again, this is very product centered, but they come in and say point number 4 is effective implementation of patient blood management to optimize clinical transfusion practice. So it's still very much on the WHO agenda. What I loved about this document is how they really highlight the disparities in terms of this first looks at the population and the blood donors in the different countries according to the World Bank income groups. So where a small percentage of the global population, only 8.9%, on low-income countries, you can see the percentage of donations is even smaller. But as you go up this income level, you'll see that it sort of flips over here at the upper middle income countries, where, well, not even there yet, but in the high income countries, where you've got 41% of donations occur in high income countries, which only contribute 16% of the population. So we do need to have a look at this as well, and this is something that I believe if we treat anemia better, we can maybe improve the donations in low and middle income countries. Because 20% of donors who present to the South African National Blood Service are deferred. And of the half of those that are deferred because of a low hemoglobin. So these are people that really believe that they were well enough to go and donate blood, yet 1 in 5 are turned away because are first-time donors because of different medical reasons, but anemia being the biggest one of them. So again, I think that is a huge win if we can improve our donor pool, that we can start to see this thing flipping over in terms of the amount of donations in lower income countries. And again, here you can, it's sort of the data presented now per continent rather than per income group. And you can see Africa contributes 13% of the global population, but only 5% of donations. And a similar sort of pattern is seen in Southeast Asia. So we have got a big win here. So the other thing that I think is quite scary, and why I believe PBM is maybe more important in sub-Saharan Africa, is if you look at the amount of countries in our region who are not even able to test for HIV, hepatitis B, hepatitis C, and syphilis. So yes, maybe it's not a hell of a lot of countries, but there are 4 countries that are not routinely testing their blood for hepatitis C. Maybe I say only 2, but 2 countries are not even testing their blood for HIV. So we can reduce the amount of transfusions that are going out unnecessarily to these patients. Imagine the impact, just the win in terms of transfusion transmissible infections. So forget about decreased mortality and all these other things that are shown in the perioperative setting. There's a huge win for us here as well. So 75% of the world's population live in low middle income countries. We can't assume that all low and middle income countries are similar. I think that there are huge differences, and we've got differences in our resources, we've got differences in our cultures, our priorities, and even within Africa, the burden of disease varies grossly, South versus Central Africa. So, and even within certain countries, the burden of disease could be different. But I think that we can safely assume that what we see in low middle income countries is a little bit different to what is seen in the Northern Hemisphere. So anemia is common. So almost a quarter to a third of the people in the world have got anemia. And in certain sectors, the prevalence is even higher. So huge amounts of kids have got anemia. I gave a presentation last week to be looking at implementing PBM in 2 of our private hospitals in Bloem, which is super exciting. But one of the gynaes came to me afterwards, and I said that 40% of pregnant women have got anemia in South Africa. And she came to me afterwards and she said, it's in her private practice, she can tell me it's definitely much more than 47%. So I mean, we only can see the data that we exposed to and that people publish, but people's perception is that anemia is much more common than what's even written about. And again, I think that this is important because why do we not have that data? Why have we not told our story? And that is my other challenge to you, is that we need to start writing up what we see and start working together and publish what we see. So because of this huge global burden of anemia, the WHO published this policy brief on this urgent need to implement patient blood management. And I know that Vernon has spoken about this before on this platform. So I'm not going to go through this at all, but it just shows, it's still very much on the WHO radar. And the purpose of this brief was really just to create awareness, very much to create a sense of urgency, looking at how can we look at implementation of PBM in the bigger sort of scheme of things. How can we coordinate our efforts? So again, this community of working together is emphasized, because I believe, only because I stole the idea from the WHO, is that if we work together, we can accelerate this change, and we don't need to wait for each person to get their own idea independently. So in this WHO document, they show this data from Leahy, which we show, and we all, I'm sure, are quite familiar with it, but for those of you who haven't had a chance to have a look at it, mortality. So this was a study that was done in Western Australia, and they implemented PBM in, I can't remember if it was 4 or 6 hospitals, but in between 4 and 6 hospitals, and these 6 hospitals contributed to 60% of the blood use in Western Australia. So they came in not with this restrictive transfusion trigger, but a systematic implementation of PBM in that region, and well, specifically in those hospitals. And what they showed was a significant decrease in mortality, infections, acute myocardial infarctions, and as well as length of hospital stay. And they had these key indicators which showed that the preoperative anemia decreased by 1/3, which is just absolutely impressive. And if you think of, I think in the SASO study, they said that in South Africa, we've got a preoperative anemia rate of over 40%. Imagine, if I remember correctly, it's 47%. So, I mean, the burden of anemia is almost double that than what the Australians started with. Pre-transfusion hemoglobin decreased from 7.9 to 7.3. We already at a really low pre-transfusion hemoglobin, so I doubt that that would be such a big win for us. And the amount of single unit transfusions also increased significantly from 33% to 64%, which is quite impressive. And perhaps that's even sort of a bit ambitious for us, where we don't have on-site blood banks in every single hospital. So I think what inspired me with this study is that what we are or could be doing is so important. If you think that the world population is about 8 billion, and in sub-Saharan Africa, we've got about 1.2 billion people. If we could pull together and produce like really cool data, that would represent more than 1 in 8 people. Whereas in Western Australia, where Leahy study comes from, it's really a small population. It's almost mirrors the population of the Free State. So if you think how small it is. So worldwide, it represents a tiny amount of the world's population. But yet that study that was done in 6 hospitals has guided and changed global practice, so much so that the World Health Organization sort of, highlights it and makes a nice little infographic about their findings. But just imagine what we could do if we all worked together and we showed our data, our local data. And why we need to do this is that the burden of disease in Africa is really, really different. So in Africa, 60% of children under the age of 5 have got anemia. And if you think of the implications for childhood development, how anemia affects not only your energy levels, but your academic performance, your mood, your psychosocial well-being is really predicted almost by your degree of anemia. In Burkina Faso, which obviously is not far from home, but almost all kids have got anemia. So there's a huge one. We know that we've got a huge burden of obstetric anemia, but what about anemia in the elderly? And then we've also got higher up north, we've got patients with hemoglobinopathies, malaria, and then other things that we forget about is like intestinal parasites and other parasites. And then not to forget about our huge burden of HIV, TB, and then malignancy as well. What I'm trying to say with this slide is that we are not the same as Western Australia. We have got different data, and we've got different things that we can win if we implement PBM in sub-Saharan Africa versus what. And don't want to discourage the wins that Western Australia had. I take my hat off to them, but we've got a different population altogether. And what I want to show with this slide is, often I use this just to show the students, but anemia is a disease that goes through stages. So only by the time you have got stage 5 anemia, do you have impaired erythropoiesis. So while I'm going through these stages, I'm only going to start developing microcytic anemia at stage 4, iron deficiency. So if I'm going to wait until I actually have got anemia before I start thinking of iron deficiency, so I mean, let's just, maybe I should have come in a little bit earlier. With iron deficiency, anemia still remains the main cause of anemia in our setting. But we need to start thinking about it and keep it top of mind, because there's no point in waiting for a full blood count to inform you that this patient has iron deficiency. Has got iron deficiency. Anemia only really develops late. So if you go back to those populations of anemic patients, can you imagine how many have actually got iron deficiency before they've even got anemia? So the wins that Leahy showed and that the World Health Organization quoted of reduced mortality, morbidity, complications, hospital stay and costs are really mainly wins in the perioperative anemia setting, which is different to ours. So who can benefit from PBM? And obviously the patients are going to benefit. Us as healthcare professionals are going to benefit. But in many centers, and especially resource limited centers, we've got Lesotho right on our doorstep here in the Free State. And the amount of patients that get referred to Bloemfontein just for a transfusion because they do not have enough blood in their country is actually scary. And how many patients are dying because their healthcare system cannot carry their burden of anemia. So if we could start implementing PBM and managing anemia properly, what a relief for the healthcare institution. What a relief for the hospitals as well, because less beds are being used for transfusions, for instance. What a big win for the insurers, and I wish I could convince them that this is indeed a big win. And what a big win for the ministries of health. So this is a study, well, it's not a study, it's a consensus statement that was published about 5 years ago on, I quite like the title, Simplified International Recommendations for the Implementation of Patient Blood Management. And it's written by a couple of the key opinion leaders in PBM. I'm sure you'll recognize those names. And here they also sort of come in their abstract really saying how big the problem is and why we really need to look at it and why we really need to implement PBM. And it's quite a nice read, and it's quite an easy read. It's open access, so you can all access it and read it at your leisure. But again, when you read the recommendations, so recommendations are supported by levels of evidence. So the higher or further along in the alphabets, the less levels of evidence this recommendation has. So it's sort of opinion rather than evidence or hard evidence. So the only sort of level A evidence is that there is a win for tranexamic acid and autologous blood cell recovery or cell salvage. So that's a win, and that looks like a good idea. Cell salvage, unfortunately, is quite expensive to implement upfront, and I think that it's something that might, and I think it's an absolutely excellent technology, and it's something that we should really look at implementing broadly to reduce the amount of allogeneic blood that we transfuse our patients. But I think that, you know, for broad implementation in sort of in the lowest of the low income countries, this could be something that the cost is, even though it's minimal when you compare to the cost of a blood transfusion, it could be something that's prohibitively expensive just in terms of setting the whole system up. Tranexamic acid, fortunately, is really affordable, and it's something that one could look at, you know, and perhaps that's something that one should look at, especially in the obstetric bleeding setting. So those would be the two places that there's good evidence to say that there's a win there. If you look at the others, so we need to look at preoperative screening, diagnosis and treatment of anemia, and that is the first pillar of PBM, and I think everybody agrees that that's really important. Intravenous iron, if oral iron is not tolerated, also within good time before your operation, so 4 to 6 weeks preoperative, we need to start, you know, treating the iron deficiency and treat it adequately with intravenous iron. So there's a big win, and relatively good evidence to support it. So they also say that we need to start looking at closed inline flush blood sampling for arterial and central lines. That needs quite a lot of motivation, or certainly in our setting, to start getting procurement of different systems, but it is something that one could look at. I think it's very important in the ICU setting as well. And then also these intraoperative approaches, you know, very much the second pillar of PBM, meticulous hemostasis, minimally invasive surgery, laparoscopic surgery. I think those are important and should, you know, are part of good practice, as well as the coagulation algorithms. But again, I put the big fat knife there to remind myself that these are good recommendations. And I think that, you know, for people like Matt, yes, these are perfect recommendations, because this is the world that he works in. You know, he sees the patients in the theatre. These are the things that he can implement. But in the broader setting of the average patient or person, I don't even think that it should be a patient. It should be a person. The average person is not going to come into the hospital and be considered for peri-operative patient blood management. When there's so much greater if one moves it from the peri-operative phase and more just looking at it at a public problem or challenge or solution. So I tried to look at some publications of PBM in other low-income or low-middle-income countries. So this is a study from Brazil that's not too old. It was published last year. And here they had implementation of patient blood management program based on a low-income country, adapted clinical decision support system. So this was a nice little study where they looked at, you know, just over 4,500 transfusion requests. And the things that they measured in this was the absolute number of transfusions. They looked at a red cell adequacy index, so this was saying, well, was this transfusion really indicated? And they said that yes, this transfusion was, or the red cells were used adequately if the transfusion happened at an HB of less than 9. And could they reduce the number of more than 1 unit of blood, or could they increase the amount of single unit transfusions? Similar to what that Leahy study showed us, so similar metrics. So please, I don't expect you to read this at all, the table on the right-hand side, but they developed this clinical decision support algorithm. And it's very, very, very similar to what Rob Wise developed in KZN. And it really just says, well, every time they ordered blood, they needed to say, you know, if it was red cells, they had to tick off on this list. Did it really comply with this guideline? So this was what they implemented, and they looked at all these requests and tried to see whether this helped at all. So what you can see is the total amount of transfusions, and that now is the red cells, platelets, and fresh frozen plasma. If you look at as in total, there isn't a huge big difference. Platelet transfusion practice didn't change significantly. Fresh frozen plasma transfusions didn't change significantly, but you could see that there was a big win for red cell transfusion. So I think this is what one would intuitively know in any case. They looked at the amount of single unit transfusions, so that's figure 3 on your right. So before they implemented this decision, I don't remember what they called it now, the clinical decision support. So before they implemented the clinical decision support, and after, you can see that there's a significant change or increase in the amount of single unit transfusions. And the red cell adequacy index, so this is now red cells that were only triggered at an HB less than 9, improved dramatically. So this really probably suggests that before this, they were possibly overusing blood, and maybe something that we won't see in our setting. Okay, so this is what Rob Wise had developed for his hospital in Edendale, and Universitas Hospital here in Bloem has now adopted this, and we've now made it our Free State Department of Health document that we use in our hospital now to guide our transfusion practice as well. So we hope that we'll see similar results in that. So I want to challenge you next. So we always talk about single unit transfusions. So like you know, there was the sort of the campaign of why give two when one will do, and I quite liked its jingle, and I think that it's really good. We need to start teaching people. I know that when I got taught to transfuse blood, somebody told me, somebody that I respected a lot, told me, if a person needs 1 bag of blood, they definitely need 2 bags of blood. And that was a fact, and I adopted that wholeheartedly because this person I really respected, never wanted to disappoint again by only giving 1 bag of blood, because I got reprimanded for only giving 1 bag of blood as a junior doctor. So we have to change this and start teaching people that we need to give 1 bag at a time and assess this patient in between. There are challenges to this, and I think that we must be practical when we sort of come up with these big fat recommendations. Why give 2 when 1 will do? And it's all good to say this when you're working at a hospital with a 24-hour on-site blood bank. But if you're working in a rural hospital that's far away, you know, an hour or 2 away from the nearest next blood bank, how on earth can we now make this the metric that we're going to use nationally, or even, you know, in our region in sub-Saharan Africa? You know, is this really appropriate, and is it even ethical to tell people, well, you must only give 1 bag of blood and, you know, reassess and then send off the courier for a 2-hour drive to the blood bank and a 2-hour drive back to the hospital? So we need to be very careful before we just take recommendations from, you know, our high-income countries and just try and sort of apply them without thinking in our local setting. However, I do think that we should be implementing more single-unit transfusions. So then the next thing would be, so why give 1 when none will do? And I think that we really need to start challenging ourselves. So why are we trying to give less and less and less when iron is actually best? And if we say that 50% of all anemia, even locally, is iron deficiency anemia, why are we still struggling to give iron? Why is iron still this sort of mystic creature that we're so scared of transfusing? And can we not look at demystifying iron infusions and giving what is best for the patient? Because a transfusion is going to fix that HB for maximum 120 days, whereas a bag of you know, a total dose infusion of iron is going to fix that patient's iron deficiency, hopefully for good, if you also actively managing the reason why this patient is iron deficient in the first place. And I think that iron, or any other decent anemia management, is really still the best way to manage anemia. And I mean, we know that. I think we're probably preaching to the converted. So my question now is what are we doing locally? And I really want us to talk about what are we doing, because we know that PBM is good. There's good data, but yet are we doing anything, or are we still sort of in the let's talk about it phase? What do we need? Do we need better education? Do we need to start getting patient advocacy? And are we being leaders? Are we being leaders? And what are the priorities in our setting? And how can we make this real for us? Because I don't think that our priorities are the same as the priorities in the global north. So, I mean, so I'm coming back to like the iron thing. It really is a no-brainer. Even if you're paying full price for iron in the private sector, I'm going to show you a slide now, it's still cheaper than a bag of blood. You've got a lower risk of having anaphylaxis or any other hypersensitivity reaction with a bag of iron than with a bag of blood. And it's much bigger. You can give a total dose infusion of iron over 30 minutes, whereas a bag of blood over 4 hours take up the 6 hours. You know, and that's if the patient was lucky enough to get only 1 bag of blood. We need to replete the iron. And don't forget that we live in a continent where we, like I showed you right in the beginning, a chronic shortage of blood. So I made this little thing just to show you that if I fully investigate the iron deficiency or the anemia, let's even look at the minimum test that you do to investigate anemia. In the private sector, at one of our private labs, it's got a national footprint. It's going to cost you $1,800 to sort out the anemia. If I'm going to transfuse this patient, it's going to cost me 4,800 Rand. If I'm going to give the patient one of the available irons, it's going to cost me 4,500 Rand. You can give, so these are the sucrosomal irons that I think are good. And incidentally, both of them have got exactly the same molecule in them. So whether you want to pay $300 or $200, it's up to you, but you're getting the same iron. So my point with this is that we really need to start looking at better management and better stewardship of the money that we have got available to us. So I wanted to ask that at this stage that we challenge ourselves to think, well, what are our priorities in terms of PBM, even if it's just in your world of work? And what are our easy wins that we can start looking at ways that we can work together better? And where the sweet spot is where our priority and our easy wins meet, because that would be the best place to work at. And yeah, so I thought that perhaps we could discuss that a little bit. And while you're getting some courage to discuss that, I wanted to tell you that we have got a short learning program in PBM that is starting very soon at the University of the Free State. It's fully online, and you don't need to get out of the comfort of your own home to do this course. We're so proud to work with Sandus, who've been the most amazing partner to work with in terms of developing something that is just, well, I'm so proud of this course. And if you would like to know anything more about it, please contact me, or else you can follow this little QR code if you want, so that then you can just click on that and then we'll join you onto our mailing list for this PBM program. And if you are not a doctor, please also click on that link, because we are going to be launching an education program for nurses as well as laboratory technologists. So we'd like to keep you on the mailing list and let you know when those are available as well. So we hope that our nursing program will be up by January next year, and our laboratory program will be available probably about in the second quarter of next year. So back to our little talk, is what are our priorities and how can we work together? Thank you very much, Matt. And I'm going to let you chair and manage the discussion that we can have fun together.
Thank you, Claire. That was a fantastic talk. I was busy summarizing as we were going, and I was nodding my head along with many of the points that you made. It asks a whole lot of questions, and which we will get to now. I just wanted to say congratulations to the team from Free State, to you and Marius and everybody else working on that online patient blood management course. The material looks fantastic, and I would highly recommend that if you are interested in improving your knowledge and to go ahead and to join that course, email Claire for more information. I think it's hugely beneficial, because one thing we do seem to know is that we do have a lack of knowledge. Every day, the people that we speak to, there's always somebody new that comes along and thinks, oh, this is interesting, this does make sense, and hopefully we can slowly start changing hearts and minds across the continent. And I want to share with you just briefly on my screen here. We've got a moment. This is an article, you should be able to see here, an article here from the World Federation of Surgical Societies for Anesthesia, an article on, what have you got?
We see your email.
That's probably not the best thing to see. Are you sure you don't want to see my email?
Okay, I think you got it. Thank you.
Yeah. All right. And so this article is talking about major elective surgery in children, and it's based talking about sub-Saharan Africa. And this particular scenario, they're talking about a case of a patient with a neuroblastoma, and it's a patient that is likely to bleed intraoperatively. I want to just highlight that one of the management strategies in sub-Saharan Africa is to make sure that you have 2 family members with a matching blood type or other appropriate donors available in the theatre waiting area with direct communication from the theatre, the surgical team. This is the sort of the scale of the problem that we're dealing with here in sub-Saharan Africa. We have immense challenges in setting up blood transfusion services. It's an expensive service. We are fortunate in here in South Africa that we have a world-class service here in the Western Cape and throughout the rest of South Africa. Even though we are able to donate more than 3,000 units per day, it's still, we had a crisis not long ago that we had less than half a day's worth of blood in KwaZulu-Natal left. So it's up to us to try and figure out how best to set our priorities and how we're going to appropriately use the blood that we do have available and how we're going to optimize the patients. So I'm going to open the floor to discussion about any questions that they may have for Claire. And any thoughts on how we can collaborate on our various research priorities and implementation priorities in this area.
So Matt,
yes.
Sorry, if I can jump in, I think one of the big challenges is that we have is data. You know, and we need to look at ways that we can work smart with our data, that we can in some way work smart and work together, that we can, you know, develop this database of what are we seeing, what is real and what is our real world, real lived experience, and not only, you know, have all these little single center studies, and that really is my challenge, is how can we use that, because data drives implementation. If we can go to funders, and if we can go to ministries of health and say, this is what we are living with, then we can drive change. And I believe that that's the way that we're going to implement it, rather than coming with data that is foreign to our setting. We need to show what's lived for.
Claire, I think you hit the nail on the head in terms of, you know, looking at the Western Australia data. It was a great study, but how do we actually implement a similar sort of study here in, we say South Africa, for example, but collaboration, and you mentioned database, and big data is what we need, and using databases is a very, very not necessarily easy, but it is, maybe this is the low-hanging fruit you were talking about. Freddie, you've put up your hand. Lovely to see you. How's it?
Lovely to see you, and really, Claire, congratulations for this. Well, double congratulations first for your great talk and for this course here. That's really, really inspiring. I had to go through the material, and then I can confirm with you, Matthew, it's really fantastic. And yes, I wanted just to intervene in regarding the data. And it's, I don't know if really it's just a viewpoint. I cannot really emphasize more on this, because as we see nowadays in the world, coming this single study centers doesn't impress anymore, because the first word is really moving to this big data. And I think it's time now where we aggregate our effort to get this multi-center data. Yeah. But now, let me just ask then a question, because in our setting here, anemia is quite very prevalent. We are just, well, 2 studies that will be soon published, we are about 50% pre-operative, I'm sorry. Is it the same for you, that side? And Western Cape, they're more advanced, they have data. but the rest of the country here, the data is quite not really. I know you had some thought of your side. Is it the same as ours, or you have got same setting as the Western Cape? Thank you.
Claire, would you be able to answer?
I don't know what what our data says, and I think that is the important thing, is that we don't know yet, and yeah, so I don't have something to answer on that really, Freddie. I think that is my challenge.
I think we need to be looking at creating. I mean, we've seen how successful even just the sub-Saharan PBM group has been in terms of distributing information. But this is a leverage point to create these big data groups, because we have representatives across Africa, and this is an opportunity to leverage various those that are involved, that are on the ground, and then also to connect with role players like the surgical outcomes teams, ASOS. We've got a robust line of communication and research networks that we can use to create these databases, and look at these data points and start collecting information. I think another point, I just thinking about it, you made a mention of malaria, and I'm wondering what sort of effect the new malaria vaccine that's being rolled or being tested, or given that malaria is one of the major causes of pediatric and adult anemia in Africa, how that's going to affect perioperative anemia.
Yeah, these are things that we should be measuring, hey, Matt, that we know what our baseline is, because if we don't know what the baseline is, how can we ever measure what the effect of an intervention such as that is? Yeah.
And then just one last thing, you mentioned cell salvage, and there's something that I'm quite passionate about. I had a case on Monday, liver resection that bled 9 liters. Because we had a particularly efficient cell saver and we were able to retransfuse 3.7 liters, we were actually able to avoid allogeneic blood products, well, these packed red cells. So that the technology that exists, there is going to be slowly a democratization of this technology. We're seeing new technologies come from, as were presented at SASA recently, which demonstrate that cell salvage is going to become cheaper and more widely available. And hopefully that's going to be using the patient's own blood, and rather than letting it go into waste, might make a huge difference. It's particularly in areas where it's difficult to access blood on demand. Claire, you had your hand up for a second.
I actually was clapping.
Oh, is that a clap? But you know, as you say, the tech comes with certain setup costs. Before I close, are there any other comments or questions, words of wisdom? Someone wants to put up their hand saying that they were happy to run a research project for the whole of sub-Saharan Africa.
Sounds wonderful. Who's that person?
How about somebody who's got the funding that will allow us to buy clinicians time to run a database and to run a project like that, who's able to write the grant for it? That's what we need. Claire, are you volunteering?
I wish, and I wish, because I think that that's exactly what we need, Matt. We need, you know, we need collaboration, and we need funding. But I can't volunteer, because then I'd be teasing you all, because I honestly don't have the capacity to do that.
Well, so let me put it this way. The cost of the Elise project in Western Australia, Freddie, I see your hand, I'll come to you now. And the point was that the implementation cost was 18 million Australian dollars. The cost savings were in the region of 105 to 110 million Australian dollars. So it makes complete economic sense, but where are we going to get $18 million from? This is where someone who's able to write grants to provide the time for us to actually do this is so important. Freddie.
Now, maybe we need to tease out what are the skills that we have with us in this network.
Yeah.
Or if we do not, because basically we may not have, not everyone has stood up in writing grants. But as you know also, in writing grants, you have also need to have some history. They won't just give money to a novice researcher who has no name. So even we need to start, but what is really possible? If people who have, that's a plus. I see Chris has left his hand, maybe is more suited to answer your wishes than me. Thank you.
Chris, I think you got the final
Sorry.
word. And we're gonna
Yeah,
close.
quickly, Matthew. Sorry, I changed locations, but so using our network, which is really a GI hepatology network, loose association of about 15 sub-Saharan countries, we've used the Gecko forum to actually get quite a lot of data. So I think keep it simple to begin with and look at a review. And if there's no data, it's very important to say there's no data, but you don't know there's no data until you look to see if there's no data. So how we started, we did reviews in a number of subjects. We did them in viral hepatitis, fatty liver disease, hepatocellular carcinoma, inflammatory bowel disease. And we're doing 2 now in endoscopy and H. pylori infection. And Lancet GastroHep has taken absolutely every one. You know, the second most cited journal, gastroenterology journal, second to Nature. And I mean, we've had 7 in the last 18 months. And I know the editor of Lancet personally, and he will take, within reason, anything from sub-Saharan Africa. So using this network, you might want to consider putting out some questionnaires, which can be voted on very easily. We've got the logistics. Do you have these facilities in your country? Do you have access to testing? Do you, just simple demographics to begin with, and it gives you a start. Look at what the data, see what any data exists, and then through the African Union, we've also got some very nice data which shares, spending per capacity, number of hematologists in sub-Saharan Africa, number of physicians, how many of blood donating organizations, and then you compile the two and you get a pretty nice review, which is a starting point. I think, trying to raise grants and write grants and putting sort of money, I think delays things, and you can get a pretty good start using this forum, and you might just want to consider it.
Thank you, Chris. That's very kind of you, and thank you for the excellent suggestions. I think we're going to close the chat, and thank you everybody for attending. I think we're at up to 47 people, 48 people online. Thank you so much for your participation. I want to thank you to the sponsors and for the Gastro Foundation for the amazing support over time. The recordings will be available on the Gastro Foundation website. You can check it at a later stage. We thank you to the iEcho teams from University of New Mexico and iEcho India. And thank you to all the participants, and particularly to Claire. Thank you so much for your fantastic talk and for stimulating further discussion, and hopefully some research, some robust answers, and continue to move forward. Thank you all for participating. We'll see you soon.
Thanks, Matthew. Thanks, Claire.
Thank you,
Cheers,
Chris.